In this session, we're going to discuss the impact of growth and development and the patient's developmental stage on their reaction to an ostomy and their learning style and your rehabilitative care. So first of all, why is this important? And of course you already know the answer because I'm sure all of you have taken courses in growth and development. So you're certainly aware that the developmental stage will affect both the patient's response to the ostomy and that their developmental stage might impact on their ability to learn and their specific learning style. That means that you and I must consider the patient's developmental stage when we provide education and counseling for the patient and for the family. Now, I want to make it really clear, when you look at your hard copy materials, your hard copy module, or your online materials, you're going to have information about Piaget and Erikson. But the faculty is going to focus on the very practical aspects of growth and development and the specific ways in which we as ostomy nurses should modify our approach based on developmental stage. So what that means is when you're studying this content, when you're preparing for the exam, you want to focus on the concrete implications for you as an ostomy nurse in providing rehabilitative care. We are not going to ask you about Piaget. We are not going to ask you about Erikson. They did great work. We totally support everything that they've taught us, but that's not what we're going to be asking you. Okay, so we're going to start with infants and we're going to go all the way through to older adult. Now, it depends on your care setting whether or not you will be involved in the management of infants with stomas. Certainly, if you are in a large teaching center, you are going to have patients in the NICU who do have ostomies because either they develop necrotizing enterocolitis or because of congenital defects. Obviously, when you're working with an infant with an ostomy, your primary focus is on the parents. All of your teaching will be done to the parents. And they are the ones that you will be doing your primary interaction with. They're the ones you're going to be assessing. The infant, yes, but the parents, you want to see how they're doing, where they're coming from, how they're dealing with everything happening to them. And they will be your primary focus in terms of education and support. So in looking at the needs of the parents, you want to step back and think, okay, now what are these parents going through? And most of them are going through a lot. First of all, many of them are grieving the loss of the healthy child they thought they were going to have. So when people are pregnant, of course they have all of these thoughts and plans about their baby. And they all revolve around babies that look very much like the one on top. Healthy, alert, and then they got something very different. They didn't get that healthy baby. They got a baby, maybe a very premature baby, who they're not even sure is going to survive and who has a lot of issues. Or they have a baby with birth defects. That's very, very difficult. So parents of children with major medical problems, parents of children with birth defects, have two challenges. They have to grieve the loss of the healthy child they thought they were going to have, as well as come to terms with the needs of the infant that they do have. So what we want to do is we want to be there to support them. We want to recognize that they have lots of very difficult emotions going on, as well as a lot of questions. A lot of times they're worried about the baby's survival. They may be very worried about the baby's quality of life long term. Some parents say they're not even sure if they should invest in the baby. Should they bond with that baby? Because what if the baby doesn't survive? They've already gone through so much pain. So sometimes they're in a lot of pain and they're distancing themselves. They're reluctant to step forward and get more involved. Sometimes they have difficulty bonding with that baby because that baby's not the one they were expecting. This baby has all of these issues and problems. And they were expecting to be at a very happy point, sending out photos and everything, and instead they're providing explanations of things that they don't totally understand themselves. All of these very mixed up, crazy, awful feelings, totally normal. Sadness, anger, some rejection of the infant, difficulty bonding with the infant. In the midst of all this, they're asked to make a lot of decisions about their baby's care. They're asked to sign operative permits. People come in and talk to them. I remember coming in and talking to the parents of a baby with multiple birth defects. This little girl had spina bifida, she had myelomeningocele, she had hydrocephalus, she had a cardiac defect, she had bladder atrophy, she had imperforate anus, she had club feet. And when I came in to see the parents, they had just seen a whole series of surgeons. And what they were involved in is trying to determine which surgery was the highest priority, who went first, to try to correct the multiple issues that this baby presented. On top of that, the baby was born with ambiguous genitalia, and they weren't even sure of the gender until the lab work was done. And the mom felt so guilty because she already had 3 boys at home, and she had prayed over and over that this baby would be a girl. And she said, I wanted a girl, and now it's my fault. I wanted a girl so much that this is how I got a girl. Because at that time, and if you had an infant with ambiguous genitalia, even if the baby was determined to be chromosomally male, they did gender conversion because it was much easier to create a functional vagina than a functional penis. So the mom, in addition to dealing with all these other things, grieving the loss of that perfect baby, trying to come to terms with all of the needs of this baby, trying to make appropriate decisions, had overwhelming guilt because she felt that she had caused this by wanting a girl so badly. So we had to spend time talking about whether that was reality-based, and if in fact that was likely to have anything to do with what had happened to this baby. And of course, it had nothing to do with what happened to this baby, but she needed to be able to say that to someone who could hear her and who could help her process. My point is that these parents are in a very difficult place. Sometimes they have just seen a whole series of healthcare providers who have come to them with this question, this decision, this piece of information. You might be the first one who goes and sits down, tells them who you are, and says, first of all, before we talk about anything, I want you to know how sorry I am for everything that's happening to you, everything that's happened to your baby. Secondly, I want to know how you're doing. How are you feeling? What are your questions? Give them time. Finally, they might have resource issues. Just because your baby's born with multiple problems doesn't automatically mean that you have the financial resources, that you have the human resources that you need. Some of these parents have children at home and this very sick baby in the hospital. And maybe they don't have other family members close by. So then they're juggling the needs of their sick baby and their children at home. Very difficult time for these parents. So what can we do? Lots of times we feel like we can't do anything because we want to make everything right. We can't make everything right. But we can reach out to those parents and we can make a difference to those parents. So as we've already said, you want to spend time talking to them, hearing them, giving them permission. Even if you say nothing beyond this, if you say something like, even if you're not ready to really talk about it right now, I just want you to know that we all know this is an incredibly difficult time. It's one of the hardest things that can happen to someone is to have a baby with a problem. And I want you to know that it is totally normal to have all kinds of mixed up feelings. It's totally normal to feel angry that this happened to you. Of course, you feel very sad. A lot of parents have trouble even connecting with this baby right at first because this is not the baby you were expecting. Give them permission. One other thing I did not mention, but I should have mentioned, some parents get blame from other family members. Some mothers especially are blamed by other people in the family who say things like, you must have done something wrong. It was something you did when you were pregnant. We haven't ever had this in our family before. So sometimes you have to debunk myths and misconceptions. And you'll know you need to do that when you sit down and you talk to people and you hear what's going on and you hear what they're dealing with. Then you can be very appropriate and very individualized in your support. If at all possible, if you have a support group for the parents of sick children or children with birth defects, refer those parents to that support group so that they're not so isolated, so they don't feel like they're the only ones, so that they can talk to other people dealing with the same thing. Also, role model. Sometimes when you have a baby who's sick or a baby that looks different, a baby whose bladder's on the outside, a baby who has an ostomy pouch, that baby looks foreign to you. You can forget that that's the same, that baby has the same needs as any other baby. So when you go in, you want to talk to that baby. You want to talk to the baby, do baby talk, pick that baby up, cuddle the baby. You want to tell the parents, oh, he's so cute, she's so cute. Focus on this, focus on that baby as a person, as a baby. And invite the parents in. Role model for them, and then invite them in. The good thing is, teaching is not usually an issue. You can usually delay teaching until the parents are ready because most of these babies are going to be in the hospital for days to weeks, some of them even months. So that means that we can do teaching in little bits and pieces, or we can delay teaching altogether until the parents have dealt with some of the intense grief and are at a better point to be able to participate. Finally, once babies start to do a self-exploration, and that occurs pretty early where they start sucking on their fingers and their thumbs, they're going to start exploring. They're going to find that pouch. And pretty quickly they'll learn to pull the pouch off, and they'll learn that they get a lot of attention when they do that. So once the baby starts that self-exploration, you want to put them in one-piece sleepers so that they can't get to the pouch. Okay, moving on to the next phase. This is the toddler and preschool phase. Most authors say this begins about age 2 and continues till about age 6 or 7. So here you have a little girl, and you can see that she has an ostomy because her pouch is hanging out under her shirt. So I want you to go to the bottom point on this slide first. I probably should have put it first. The ostomy in the pouch does not usually bother the child. To the child, that's normal. That's what they have. They think everybody else has it. So I've had little kids go up to other little kids and say, where's your bag? Where's your pouch? They think something's wrong with the other kid who doesn't have a bag, doesn't have a pouch. So they're very accepting. When you're looking at working with a toddler, you are focused on their needs and helping them to progress, but again, you're focused on the parents' needs because again, the parents are the primary caregiver at this point in the developmental pathway. In talking with the parents and addressing their needs, you want to remember the concept of chronic grief, chronic sorrow. And what we mean by that, I think we might have talked about that once before, is that if your child is born with a birth defect, you have intense grief work at the time of birth. But does that grief go away? No. It doesn't go away unless the problems all go away, and many times the problems do not all go away. For example, I've had a number of children as patients who had spina bifida. Well, of course, parents had intense grief work at the time that their child was born. But the thing is, spina bifida causes lifelong issues. So these kids have bowel and bladder issues. They either are paralyzed from the waist down and are wheelchair bound, or they're braced and on crutches. Some of them have hydrocephalus. Some of them have other orthopedic issues. I remember talking to a mom whose little boy had spina bifida, and I just asked her, I learned to ask every parent, how are you doing? How are things going? You know, how are things going for your little girl? How are things going for your little boy? How are they going physically? How is he or she doing emotionally? And how about you? How are things going for you emotionally? Because this takes a toll, not just on your child, but on you as well. And it doesn't go away. I know it doesn't go away. And one mom told me, she said, you know, most people don't realize that the pain doesn't go away. They think you get over it and that you're okay with it, but you're never okay with it. She was telling me, she said, I'll have periods of time when I'm okay, when I'm doing pretty well. When my little boy is at a stable point, I'm at a pretty stable point. But then he will hit another developmental milestone. He will have increased awareness of his limitations. And all of a sudden, I'm right back there grieving again. And she gave me an example. She said, for example, last week, he said to me, Mom, I wish I had been born first, not second, because he had an older brother. And she said, well, why do you say that? Why do you wish you had been born first and not second? And he said, because then I'd be able to walk like the other kids, and I'd be able to pee like the other kids, and I wouldn't be different. And she said, oh my gosh. She said, I held it together, talked to him, and then she said I fell apart because I see my child hurting, and when I see my child hurting, I'm hurting. So recognize that these parents have an ongoing challenge in adaptation. Ask them, hear them. That's all you can do. It's a tremendous gift. Now, also be aware that frequently parents who have children with special needs, whether they're physical needs or emotional needs or whatever, parents can become very overprotective because they don't want anything bad to happen to their child. I once worked with a mom, and I had not seen her before. I picked her and her little girl up when her little girl was in first grade. And so I'm asking her, so how is your little girl doing in terms of changing her pouch at school? And she looked at me like I had two heads, and she's like, well, she doesn't change her pouch. I'm like, oh, okay, so what happens if she has a problem at school? And she says, well, they call me. I don't go anywhere when she's in school because I know they can call me anytime, and if they call me, I go straight to the school. So you have to always ask questions to find out how much independence that child has and how much protection that parent is providing. And then you have to intervene, and we'll come back to that. Now, normally what we should see in kids between ages 2 and 6 is increasing levels of independence, increasing ability to do their own self-care. And in fact, we expect kids to be independent in basic ostomy care by the time they begin first grade, which is usually right around age 6, certainly by age 7. So that's kind of our target goal. And that means sometimes we have to help the parents. So, ongoing support for the parents, we've talked about that. We have to constantly evaluate the pouching system because the child's activity level is constantly changing, their abdominal surface is constantly changing. So we might have started out with an all-flexible one-piece system because of that soft, rounded baby abdomen. But as that toddler becomes more active, we may need to change to a firmer system. We may need to put them in a two-piece system. Typically, we do need to keep them pretty much in the one-piece sleeper kind of things, something that keeps their fingers away until they're old enough to have basic understanding and not to pull the pouch off and, use stool as finger paints. Now look at the third bullet point. This is very important, and that is increasing the child's involvement in ostomy care. So you're going to work with the child and the parents. A lot of times we will do play therapy, so we'll take a doll or we'll take a stuffed animal and we will apply a pouch to that doll or stuffed animal. Hollister has some stuffed little dolls. They're pouched in series that you can use in working with toddlers so that they see their doll has a stoma, they have a stoma, their doll has a pouch, they have a pouch. So you want to say to the parents, now remember we're entering a period of time that's going to be several years long where we are going to move from you doing everything to your child doing everything because we're getting him or her ready for school. So let's think about where you want to start. It's like, oh, it's a nightmare for me to even think about her doing anything with her pouch because she'll just make a mess. That's absolutely true. What happened when she started feeding herself? She made a mess. Did you let her feed herself? Well, yes, I had to. She's got to learn to feed herself. Exactly. So I have some tips about minimizing the mess, but bottom line, we've got to teach her how to do this. It's kind of like potty training for a child with an ostomy. So why don't you first begin by letting your child take off the old pouch. Just teach them how to push on their skin, pull on the pouch, push, pull, push, pull, push, pull. So let them take off the pouch. That's not going to create much more of a mess than would have occurred anyway, and you can do it in a protected environment. And then, once the child is comfortable with that, and you're comfortable with that, why don't you give the child the little wet cotton ball or very soft wet paper towel and teach them to clean around their stoma, because at this point they're washing themselves, they're washing their faces. Okay, let them start cleaning around the stoma. You're still cutting out the pouch. That's a much higher level psychomotor skill. You're cutting out the pouch, but they're taking off the old pouch, they're cleaning their skin. Then as their dexterity and their eye-hand coordination improves, you can work with them to have them stand in front of the mirror and fit their pouch over the stoma. They're going to need to be able to do this when they go to school. So step by step by step, you move that child toward independence. Now, one point to you as the ostomy nurse, you might need to modify the pouching system. You might need to make it simpler. Children are not going to be able to do paste. It's going to be a disaster if you try to have them do paste. So you might change them to a moldable wafer where they can just stretch and fit around the stoma. You might decide, okay, it's not really feasible to teach this child at this point to manage a drainable pouch because that takes a lot more dexterity to open the end and drain and clean and close. Maybe it's more appropriate to put them in a closed-end pouch or a two-piece system with a snap-on, snap-off pouch with a closed end where they can just snap it off, throw it away, snap another one on. Work with the parents, work with the child to come up with the simplest system possible that will work for that child, and then to put a plan together that gradually increases that child's independence in ostomy care. Okay, moving ahead to school-age children. Obviously, school-age children are much more independent. They manage almost all of their self-care unless they have some coexisting issue aside from the ostomy itself. Also, during school-age years, children start to identify more with their peers and to be more involved in peer-related activities as opposed to doing everything with their families. So their friends at school activities become more important. Now, this of course is variable because some children do have some cognitive impairment or they have some other functional issues unrelated to the ostomy itself, and you always have to take those into consideration. But from the perspective of the ostomy itself, if this child has an ostomy because of congenital anomaly involving the GU or GI tract and their cognition is normal for their age, and their functional status is normal for their age, the ostomy really should not be holding them back. And we want to find ways to make sure the ostomy is not holding them back. So we always do our assessment, what's going on, what else is this child dealing with. If it's primarily the ostomy, then we want to do everything possible to minimize the impact of that ostomy on this child's quality of life. So we're going to assess their level of independence, and we are going to do whatever is necessary to take them to total independence. We want them to be able to manage anything that happens at school. We want them to be able to go on school trips. We want them to be able to go to camp. We want them to be able to go to overnight sleepovers. If there's not another issue that is limiting their ability to participate, we want to make sure that the stoma does not play a limiting role. So we're encouraging them to be independent. We're working with them to solve any problems they're having with ostomy care. We're asking them, so what do you like to do, and what's going on at your school? Do you like spending night parties? Have you gone to camp? You're talking to the parents and the children, and you're saying directly to the parents, you know, I really want to work with you to make sure that the ostomy doesn't play a limiting role in your child's development. I want her to be able to do all the things they want to do. I want them to be able to go over to their friends' houses. I want them to invite people to their house. I want them to be able to go to camp. I want them to be able to go to birthday parties. I want them to do the other things they want to do. Because sometimes parents get back into that protective role where, well, I don't think it's a good idea for her to go to a sleepover because what if something happened? You know what? Your little girl is very smart, and I think we can absolutely teach her how to manage should she have an accident. I think we can teach her how to manage that. Are you okay with us talking to her about that and finding out what she wants to do? Many times you take the lead and kind of encourage, push, pull. Okay. Finally, you might need to intervene with the school. I just noticed that last point, and I did want to mention this. Probably a lot of you are aware that in many schools today there's very limited privacy for children in the bathroom. Also, in many school systems, children can't just raise their hand and ask to go to the bathroom. They have to wait until approved bathroom breaks. But children with an ostomy need access to the bathroom. This is also true of kids with incontinence issues, etc. But right now we're focused on ostomy care. So you might need to either write a letter. I've written letters. I've also gone to the school to meet with the teachers and to say, let me explain what's going on with Charlie. Let me explain what's going on with Wendy. And let me explain what they need. So I show them the pouch. I explain to them what the stoma is, how the pouch works, and then I tell them exactly what it is this child needs. Specifically, what we're typically asking for is for this child to have PRN bathroom privileges, meaning they can just raise their hand and the teacher will nod their head that yes, they're excused to go to the bathroom. And they need to be able to go to a bathroom with privacy. If there's no privacy in the school stalls, they need to have permission to go to the bathroom in the school nurse's office or the faculty lounge or whatever. So assess the child, work with the school. Okay, what about teenagers and adolescents? Well, of course, we know a lot about teens and adolescents. We know this is a very difficult time in any kid's life. It's a lot of upheaval, a lot of turbulence, a lot of emotion, a lot of drama for the kids, for their parents. Again, increasing focus on peer activities. They're moving away from being parent focused and parent driven to being very peer focused, being much more concerned about what their friends think than about what their parents think. Of course, body image issues are a huge concern. They're moving into puberty, into sexual maturation, so a lot of times they have concerns about dating, they might have concerns about sexuality. And these kids do not want to be different. You can remember when you were a teenager, you wanted to fit in. You wanted to kind of look like the other kids. It's okay if you look a little bit better, if you're a little better looking than the other kids, if you're a little bit smarter, but you want to stand out only in a positive way. So fitting in, huge to these kids. So what can we do if we have a child or a teenager who has an ostomy? And we will have kids who have ostomies, even if you don't have peds in your agency. A lot of times teens are admitted to adult units, and you know that the teens and 20s are a peak period of time for inflammatory bowel disease. So you will definitely have teenagers who require ileostomies because of Crohn's disease. Might be temporary, might be permanent. It might be for another issue as well, but probably inflammatory bowel disease, familial polyposis, the most common. Always, you go back to what does this kid want? This kid wants to be normal, wants to be independent, wants to fit in. That's usually the driving force. You want to assess this kid. What are they worried about? What are their concerns? You are going to focus your interactions on that teenager, not on the parents. Okay? Now you want to make time for the parents and you want to include the parents. But when you're talking about the ostomy, when you're doing teaching, you're talking to the teenager, because who's going to be taking care of the ostomy? The teenager. Who has the ostomy? The teenager. And if I direct all of my interaction to the parents, what am I saying to the teenager? You're still a little kid. And what are they trying to prove? They're not a little kid anymore. Okay, so focus your interactions on the teenager. Find a time when the parents are not in the room and give that teenager a chance to ask any questions that they have about their body, about sexuality, about dating, that they might not want their parents to hear. So what I have done that's worked very well is I've just said to the parents, you know, I'm gonna watch Charlie change his pouch, or I'm gonna, you know, watch Tammy change her pouch, and so I'm gonna let you go and take a coffee break. And that way there's not so many of us looking at her, and gives you a little bit of a break too. And if the parents are like, no, I'll stay here, I'll say, well, walk outside with me. And then I'll say to them, you know what, it's really a good thing if you go and take a coffee break, just take a little bit of a break. It's important for Charlie, it's important for Tammy to know that they can do this on their own, and that's the message we're giving them. So I need your help here. And then once the kid gets through doing what they're doing, you want to say to them, I wanted to give you a chance to ask any questions you might have that you wanted to ask in privacy. And you don't know what you're going to get. I have had questions all over the board. So I remember having a 16-year-old. I expected all kinds of questions about clothing and was it going to show, and how she was going to, you know, manage with dating, et cetera, all of age-appropriate kinds of things. But no, all of her questions related to food. I was very surprised because they all sounded like they would come from a 12-year-old. But when I went back and looked at her history, I realized that she had been very ill for a number of years. Her parents were very overprotective. And at the time of her surgery, her parents were involved in a very contentious divorce, and she was kind of being used by each as a pawn. So she had essentially regressed and was functioning at a very different level. She was asking questions I would expect from a 12-year-old. Typically from a 16-year-old, you're going to have a lot of questions about clothing and appearance, and is anybody else going to know, and do any other teenagers have anything like this, and am I the only one? And things that are very important for teens are to talk to them very directly about clothing, and to talk to them about using the layered look to help conceal the pouch and the stoma, wearing a very long base camisole or t-shirt, making sure that they're in a very flat pouching system so it doesn't show. hooking them up, as you see, with UOAA, who does have the UOAA website, has a teen group. CCFA has a teen group, so that they know they are not the only one. If you have a teen visitor who can come and meet with that teenager, it makes the biggest difference in the world. If you do not have a teen visitor, don't send somebody in their 50s or 60s. That does nothing for that teenager. They would look at me and say, why am I talking to you? Your life's over with anyway. Of course it's no big deal to you. No, it's got to be someone very close to their own age and somebody of the same sex. Speaking of sex, that's something else that may come up. So I remember covering for our pediatric ostomy nurse, and I was doing post-op teaching for a 14-year-old. And when I got her mom to go downstairs and I asked her if she had any questions, she said, yes, can I have sex with my boyfriend? Now you have to know that my oldest son was 14 at the time, and so my initial response was no. Then I realized that was probably the mom in me and not the nurse in me talking. So I backed up and I said, well, let me ask you a couple of questions. Are you already having sex with your boyfriend? Yes. He said, okay. So let me just go through a couple of things. There's nothing about the ostomy that keeps you from having sex. But having had this surgery and having a stoma makes most people feel a lot more vulnerable emotionally, so you need to be sure you're very, very safe emotionally with your boyfriend and that you talk about this first. And we probably want to talk about some things that you could do just to secure and conceal your pouch if you do decide to go back to having sex. So the other thing you need to know is that having an ostomy in no way protects you against anything. It doesn't protect you against pregnancy, doesn't protect you against STDs, so you've still got to use protection. So just take it slow, take it easy, protect yourself emotionally, protect yourself physically. So give them the chance to ask their questions and know that you may get some questions that you didn't really expect. But the bottom line you want that teenager to know is, you know what? You can do the same things your friends are doing. You can pretty much eat what they're eating. There might be some minor modifications you need to make based on your ostomy. I'll individualize that for you. Can you go to prom? Yes. Can you go on trips? Yes. So that's our message to everybody. We want to find ways to keep this ostomy from having a negative impact on your quality of life. Young adults, that's where most of you are. The young adult years are typically considered to be between about 20 and 45. And when you think about your life experience, and when you think about meeting someone new and the kinds of questions you ask each other as you get to know each other, typically we ask people, so what kind of work do you do? What do you like to do for fun? Are you into music? Are you into sports? Do you like to travel? And we ask people about relationships. So are you in a relationship? Are you married? Do you have kids? Are you dating? And those are the three areas of greatest concern to most young adults who have to have an ostomy. So they're going to be concerned about the impact of this ostomy on their work life. Can I go back to my current job? Is it going to cause any problems? Do I have to make any modifications in order to go back to my current job? Am I going to be able to do the things I like to do recreationally? Can I hike? Can I swim? Can I scuba dive? Can I travel? Okay. Are there things I cannot do? And how do I manage my stoma and my pouch? If I'm out backpacking, how am I going to manage that? Or what if I do a lot of water sports? How am I going to manage that? And we want to be able to help our patients with those things. And the good news is that there are now things on the market to help people manage their stomas, manage their pouches in almost every circumstance. For example, I know this is off the subject, but I'm going to mention it here. a young adult who did a lot of water sports came up with something he calls the Stealth Belt, STALTH belt. And it looks like a waterproof backpack, but it's designed to fit around the pouch and the stoma and to protect the pouch from water. And it looks just like a waterproof, well, fanny pack, not backpack, waterproof fanny pack. So there's things out there to enable people to go back and do the things that they want to do. There are very, very few limitations. There are even some hard shell devices that fit over the pouch and the stoma that can provide protection if somebody's doing something recreationally and they're concerned about any trauma to the stoma. So there's something for almost everyone. What we need to know is, what kind of work do you do? What are your preferred recreational activities? And what concerns do you have about your relationships, especially your sexual relationships? Also, we want to remember that there's the risk for, and this is particularly significant for teens and for young adults, there's a significant risk that they can become isolated because of their illness. Not so much because of the ostomy, but because the illness, the condition that precipitated the ostomy. And the reason that can be isolating is, think about the fact that a lot of their decisions are dependent on their health status at a given point in time. Well, yes, I'd love to do that if I'm doing well. Yes, if I'm out of the hospital, I have to have the next stage of this procedure done. But if I'm out of the hospital and doing well, I'd like to go do that. The rest of their peer group isn't making decisions based on health conditions. The rest of their peer group is pretty much, oh, let's do this in 3 months, let's do this in 6 months. If I have to consider health status and making decisions, it makes me different, and it can make me feel alone and isolated. Again, that's the advantage of getting people connected to UOAA or CCFA, where they're talking to other people who are just like them, who are dealing with the same issues that they are. So I think we've talked about interventions as we've gone through. We want to hear this patient. We want to assess their specific concerns. Tell me what kind of work you do. Do you have any concerns related to managing your ostomy at work? What do you like to do recreationally? And what questions do you have about that? And we've talked extensively about relationship counseling and giving information about sexuality, management of the pouch and the stoma during sexual activity. And then we've talked about the importance of referrals. Even if you don't know anyone in your area who is close to this patient's age, that's the advantage of UOAA. So they can go online to www.uoaa.org. And they can chat online with other people in their age range who have similar concerns and issues. It's really a wonderful resource. So I encourage you to explore that website so that you feel comfortable sending patients to that website. What about middle-aged adults? Well, middle-aged adults, you think, hey, that's right at the time of that midlife crisis bit. A lot happens during the middle years. That's 45 to about 62 to 65. That's when kids grow up and leave home, or they grow up but they don't leave home, or they grow up and they leave home and they come back, sometimes with attachments. Each one of those scenarios requires adaptation. So empty nest. I thought I was going to have an empty nest, but I don't. I had one and now it's full again. All of those situations require adaptation. As you know, many relationships fail during the middle adult years when kids move out. So sometimes there are relationship issues. Sometimes there are major career issues. People frequently make career changes at this point in their lives. So it's not necessarily a stable time in an individual's life. You just need to be aware that there could be a lot going on. Sexuality is still an issue for most patients, and women, of course, are dealing with the effects of menopause. Men frequently are dealing with concerns about their sexuality and their sexual performance because they're dealing with changes as well. So bottom line for us, we need to determine what's going on with this patient, what their concerns are, especially in relationship with, to the ostomy, and then we need to intervene accordingly. And then finally, we're going to talk about older adults. Now, for most of us working in the acute care, home health, or long-term care setting, most of our patients will be older. Most of them will be 60s, in their 60s, in their 70s, in their 80s, in their 90s. So I think in your online or hard copy materials at some point it says something like that most WOC nurses or most ostomy nurses are geriatric nurses. Somebody asked me, does that mean that you're saying we're all old? And I'm like, no. I meant that to say that most of us are caring for the elderly population. Now we know that there is tremendous variability in health status, functional status, and cognitive status among older adults. So I know every one of you have taken care of patients in their 80s or 90s who are doing great. They were very, very sharp cognitively. They were still functionally independent, and they were pretty healthy, except for this one thing that they're having to deal with, a ruptured diverticulum or whatever. On the other hand, you've probably had patients who were younger but much sicker. So there's the concept of elderly and then frail elderly. Frail elderly are the elderly patients who are also sick, who are also dealing with multiple comorbidities, and who are not going to bounce back, who are not going to do as well as those who are healthy. One thing we have to keep in mind in dealing with older patients is that they are dealing with multiple losses. I am sure you have heard this from your patients, possibly from, older members of your own family, where they tell you, I'm the last one in my family. All my, my parents are gone, my siblings are gone, my aunts and uncles are gone, I'm the last one. Or when my patients told me the first thing I do, the first section I look at in the newspaper is the obituary section. And then he was laughing. He's like, well, I look first to be sure I'm not missing. And then I look to see which of my friends has died. That's a very hard, ongoing situation to deal with, where you deal with one loss after another loss after another loss. I was talking to someone in the clinic just a few days ago, and he was telling me how hard it was that he's no longer able to drive. And he said, I understand why they don't want me to drive. It's really not safe for me to drive, and I know that. But it changes my level of independence tremendously, and I hate that. I liked being able to go when I wanted to go. I liked being able to take care of myself on my own. Now I have to wait for my son or wait for my daughter. And they don't mind doing it. It's not them, it's me. It's hard to give things up. It's hard to lose abilities. I've talked to individuals in high-rise retirement facilities who told me how hard it was to give up their homes. Even though they could no longer really take care of their homes independently, it was very hard to give that up. So you see that whole concept of ongoing loss. And little things, like I can't see as well. I have to have large print books. I can't read just anything that I want to. I can't hear as well. So if I don't have my hearing aid in and on, then I can't even tell what you're saying to me. And my dexterity is not as good as it used to be, and I have to use this walker. Just one thing after another after another. Helpful to be aware of that as a background. It explains why many elderly patients are depressed. We talked about the importance of screening our ostomy patients for depression. If your patient has a new ostomy and they're elderly, they're even higher risk. Be alert to signs of depression. And watch those nonverbals. I went in with a student to see a patient, and the student and I both noticed that she just seemed so sad. We had actually been consulted for wound care, not ostomy care. But we said to her, "You look really sad today." And she told us that her husband had died the day before she was admitted to the hospital. The day we were seeing her was his funeral, and she wasn't able to go. The interesting thing was no one else on the nursing staff even knew that her husband had died. No one had really talked to her about how sad she was. So pay attention to those nonverbals, ask patients. If they seem sad, find out what's going on. Sensory and hearing loss, we talked about that, but look at the last two things. I want to spend a little bit of time on this. Most elderly patients retain the ability to learn. It's a very small percentage who have any dementia. Most retain the ability to learn, but there may be a change in their learning style. Bottom line, if you're 84, if you're 95, unless you have cognitive impairment, there's no reason that I shouldn't be teaching you how to do your own care. So most patients retain the ability to master self-care. And looking at common concerns for the elderly population, one very common concern for both patients and families is the potential impact of surgery and an ostomy on that individual's level of independence. I've had patients tell me, if having this surgery is going to mean I can't take care of myself any longer, I don't want to have it. I'd rather die than not be able to take care of myself. I've had family members ask me, what is this going to do to my mother's ability to take care of herself? Is she going to need to live with one of us? Because if so, we have to start making plans. We all work. The other thing that's very likely to be a concern is the cost of supplies. Remember that many of your elderly patients will be on fixed incomes. Many of them are already trying to juggle expenses, cost of medications, and now cost of pouches and ostomy equipment. For some of my patients, that's tops on their list of concerns. So I have to keep that in mind, and I want to know if that's an issue for my patients. I want to know what their questions are and what their concerns are and what worries them about taking care of this ostomy. So management, again, we've covered a lot of it. Just being alert to signs of depression, assessing them, asking them what's going on in their lives, being alert to recent losses, assessing cognitive function and visual and hearing acuity. Now, when I say assess cognitive function, you don't necessarily have to do a formal test of cognitive ability, but you certainly pay attention to your patient's ability to follow instructions, to remember information given, that kind of thing. You're going to ask them about their concerns related to this ostomy. You're going to give them basic information about the cost of supplies. You might say, let's talk a little bit about supplies, about insurance coverage, about where you get these. I want to answer any questions you have about your supplies, and if I don't know the answer, I'll get it for you. So here's what I can tell you. Most people change their pouch about every 3 days, so they're using about 10 pouching systems a month. And the average pouching system costs this much money. And Medicare covers part of the cost, but not all of the cost. And the suppliers will file on Medicare for you. Now, let me stop there and take what questions you have. Now, if a patient's very concerned about the cost of supplies, you might want to talk to one of the DME dealers. There's huge DME dealers that we deal with all the time, Edge Park and Byram and CSS Medical and Liberty. I could call any of them and I could say, I have a patient who is on Medicare, And I'm looking at 3 different pouching systems for this patient. This patient is very, very concerned about the cost of supplies because they're on a fixed income. So would it make a difference in terms of this patient's out-of-pocket cost, whether I put them in pouch A, pouch B, or pouch C? Well, DME dealers, durable medical equipment dealers, know supplies and the cost of supplies, like we know dressings and stuff like that. So they will be able to say, oh, well, you know, that he's going to have higher out-of-pocket costs if you do this. Probably his, the least out-of-pocket cost would be with option C. Just use your resources. Now, you want to provide realistic discharge planning and counseling to the patient and the family. We don't have the ability to predict what's going to happen with total accuracy, but I can make an educated guess. And here's what I'm going to use. If this person comes in and they're totally independent at the time of admission, then unless there's some unforeseen complication or issue, I expect that they're going to get back to independence. Now, they might need to spend 1 to 2 weeks with someone else if they're not steady enough when they go home. But I expect that they're going to get back to very close to their current functional level. In contrast, if I have a patient who's very borderline at the time of admission, so maybe he or she is living independently, but their children come over every week to take them to the store, to pay their bills, to put food in the freezer. They fix meals simply by putting something in the microwave. They don't really do house cleaning or anything like that. Then I'm much more concerned that the stress of hospitalization, surgery, and the ostomy could push them back and could compromise their functional level to the point where they might be dependent on someone else. And I would want to be honest with the family and the patient and saying, you know, your mom's in kind of a vulnerable position because she's borderline. She might get right back to where she is now, but she might not get back to that point. She might have to stay with someone or have someone stay with her. She might need short-term placement in a nursing home. I just want to be as honest as I can in looking at what might happen. And then in terms of teaching, I'm going to modify my teaching approach. I'm going to realize that the older the patient, then the more important it will be to do short teaching sessions to provide more repetition because of changes in levels of neurotransmitters and receptors. So it's not that they can't learn, but I can't dump everything on them in one teaching session. So I'm going to see them more often for shorter periods of time. I'm going to plan on repetition until they're very comfortable with one set of skills before I move to the next. If they have any loss of visual acuity, I'm going to make sure I provide them with large print instructions, dark black ink, matte white paper, good lighting, glasses on. If they have hearing loss, I'm going to make adaptations for that. If they have any kind of dexterity issues, I'm going to make alterations for that. So in summary, the patient's developmental stage does affect how that ostomy impacts on them psychologically as well as physically, and sometimes it impacts on learning style. That means that when we're doing the assessment, our assessment of the patient, we want to consider their developmental stage as well as everything else that we've talked about during the last few sessions. And then we're going to individualize our teaching and our counseling based on this patient's needs. Thank you.